Hello everyone, my name is Linford. I'm one of the neurology trainees in Leeds, and I'll be talking to you today about headache. So to start off with, I'll go over a couple of primary headache disorders. I'll mention the red flags, and then we'll talk about a couple of secondary headache disorders you don't want to miss. And finally, I'll lay out my approach to the acute headache presentation. So starting off with migraine, first of all, it's by far the commonest headache disorder you will see, both in acute medicine, accidents and emergency, and in primary care. As with all headaches, 95% of the consultations should be on the history, and you're more likely to make a positive diagnosis if you nail down the history. With migraines, you have episodic migraines when they're less than 14 days a month, or chronic migraine when it's headache days for more than 15 days a month, at least 3 months. The pain tends to be more unilateral and paroxysmal and can last anywhere from a few hours to up to 3 days. Usually patients report an associated aura. This can be visual aura, although it's very often associated numbness or weakness. They also report nausea and vomiting, photosensitivity, and sound sensitivity as well. And usually I ask them what they do when they get a headache, and they tell me, oh, I try and lie down in a quiet dark room, and that's very telling of a migraine headache. Some risk factors include a positive family history of migraine and slightly higher predominance in the female population. We also question about combined oral contraceptive pill because of the slightly increased risk in migraine with aura of stroke. In terms of treatment, the guidelines now are to go for triple therapy if needed, especially if these patients are presenting to A&E when they have severe pain. So we go with a non-steroidal and anti-emetic amitriptyline as your first choices. There are different ones you can choose from, and those are the doses listed. In terms of preventative medication, this is not something that you will treat in hospital, but you can start them on propranolol and amitriptyline, which have a lot of evidence for chronic migraine. And you start at a low dose, and then you can build it up slowly to the doses that are really effective for headache. And it can take up to 3 months to have a full effect, so it's something to warn the patient about. If they failed on 2 preventatives, that's when you need to make the referral to neurology for Botox injections. One thing to note is that opioids have no role in acute and chronic management of migraine, so we don't usually use them for treatment. So I wanted to mention cluster headache because although it is much more uncommon than migraine and you're only likely to come across it occasionally, it's really important to get the diagnosis right in this population because the patients suffer from a lot of pain and it can be very debilitating. In general, the headaches classically present with a unilateral side-locked headache that is usually focused in the retroorbital region, and patients usually complain a lot about the autonomic symptoms, so nasal congestion, tearing, and conjunctival injection. The headaches predominantly happen at nighttime, so they tend to wake them up from sleep, and opposed to migraine, when the patients want to lie down and want to rest, patients with cluster headache tend to be quite agitated and restless. And as the name suggests, they occur in clusters, so the patients will get the headaches several times a day for a few days or few weeks, and then are in remission for a few months. In terms of acute management, you want to be going straight for the sumatriptan injection or spray, and we usually use high flow oxygen if they are in hospital, and give them a prescription for oxygen at home if they find it's effective. In terms of short-term therapy, you can use prednisolone, 60 milligrams for 5 days if you're struggling to get on top of the clusters. And for long-term therapy with verapamil, you want to be referring to the headache clinic. Tension-type headache is another common headache disorder. In general, it doesn't usually present acutely because by definition, patients feel that they can manage with the headache at home. It tends to be a rather featureless headache. Sometimes it can be described as a tight band around the head. It can be bilateral. It's not pulsatile. The attacks can last anywhere from a few minutes up to several days at a time. It's not particularly aggravated by physical activity, and usually patients say the headache gets worse as the day progresses. And there are a few associated features. With prevention, you can usually use amitriptyline or propranolol as well, although one of the things to look at is lifestyle factors and modifying stresses, things like sleep, good diet and hydration, and these usually respond to that. So speaking about headache in particular populations, headache in pregnancy, this usually improves in pregnancy, especially in people with a diagnosis of chronic migraine. So that's something they can be reassured by. The headache can be made worse by the usual effects in pregnancy of altered sleep, sickness, and dehydration. These are usually treated conservatively when they do present acutely, either to the obstetricians or to the medical team, with fluids, rest, and simple analgesia. Non-steroidals are usually used first line in the first and second trimester, and because a lot of the other usual headache medications have some relative contraindication in pregnancy, we use opioids if we need to, if the headache is very severe. In refractory headaches, we tend to use nerve blocks, which can work quite effectively in the short term. The red flags in this population are similar to the general population. So coming on to the red flags, some of you might have heard of the acronym SNOOP10, which is a comprehensive list of red and orange flags now, but I've just summarized what they essentially mean in these main ones on the left. And that's age, so the older population, someone over 50, anyone with a new focal neurological deficit, that's a really big red flag, and those really need investigation. Someone presenting with altered consciousness, thunderclap headache, which we'll talk about in a bit, and papilledema. Now, papilledema is very important, and that's something that is really a crucial part of the headache examination. Also, if patients are systemically unwell, so if they have fever, if they have infective symptoms, or other systemic illness, and then present with headache, that might make you suspicious. So these types are the ones you want to be investigating with intracranial imaging. Usually a CT head, plain CT is fine, but sometimes you may need contrast depending on the situation, and then further investigations. Thunderclap headache, it means different things to different people, and the definition usually defines it as being a sudden onset headache that peaks really within the first 1 to 2 minutes. So if the patient tells you the headache peaked in severity in an hour, that really isn't a thunderclap headache. And the location of the headache is not particularly specific. So the old story of being hit at the back of the head with a bat or a brick, that doesn't really work and doesn't give you the answer as to whether this might be a thunderclap headache or not. The associated symptoms can be helpful, so collapse and vomiting, if they've never done that before with a headache, might be suggestive. And furthermore, neurological signs, so anyone with meningism, ophthalmoplegia, or weakness, which goes to a neurological deficit, red flag would be make you suspicious that this might be a thunderclap headache with a secondary cause. So as I said, severity and character, less useful pointers. Now, with thunderclap headache, usually we think about subarachnoid hemorrhage, and that is usually the main concern. But it's important to keep in mind that there are a number of different causes for thunderclap headache. You can get dissection, venous sinus thrombosis, some of the vasculitides present with thunderclap headache, and you can also get the more rarer causes like pituitary apoplexy, and there is a primary headache disorder called primary thunderclap headache, although that is a diagnosis of exclusion. In thunderclap headache, one of the decisions to make is whether you're going to do a lumbar puncture for the patient, and there's no right or wrong answer. It all depends on clinical suspicion. I would say in any new headache with features that suggest it's a thunderclap headache, that is something you really want to be thinking about. Nowadays, plain CT head within 6 hours of the headache onset is very sensitive, up to 99%. But a lot of this depends on the local reporting expertise. So whether you have a general radiologist reporting it as opposed to a neuroradiologist. In the UK currently, if there's a clinical suspicion, you really need to do a lumbar puncture with a normal CT head to look for xanthochromia. With regards to lumbar puncture, this is usually done at least 12 hours after the headache onset so that you're able to detect the bilirubin, usually by mass spectrometry. And it can be done up to 2 weeks, but really after a week, you're losing the sensitivity. So you really want to be doing it from 1 to 7 days after the headache onset if you're suspicious. Usually the lumbar puncture can be delayed to working hours because you want to make sure that the lab is going to process it as soon as possible. Because even though it can be stored shielded from light, there does tend to be some breakdown in the blood products, and this can really confound the results. If the lumbar puncture does show that the CSF results show xanthochromia, then you want to be thinking about an angiogram to look for that aneurysm that might have caused the bleed. Another headache I wanted to focus on, which is not very common but can be fatal if left untreated, is cerebral venous thrombosis. The difficulty with this headache is it can present in a number of different ways, and there's not a typical headache that can make you alert about a thrombosis. But one thing to say is that there are usually red flags associated with the headache. So seizures, reduced GCS, and focal neurological signs are very common. And the headache tends to be unresponsive to simple analgesia. CT head and venogram is usually the imaging modality of choice if you're worried about a venous sinus thrombosis. And if the thrombosis is confirmed, then you really need to be anticoagulating with low molecular weight heparin to start off with. And then in the next few days, you can think about a direct oral anticoagulant to start them on for thromboprophylaxis. In terms of precipitating factors, there can be a number of factors that can lead to thrombosis. The commonest ones we see are trauma, infection, so sinusitis or eye infection that's led to thrombosis. Meningitis can be associated with thrombosis. In the postpartum period, patients with malignancy or thrombophilic disorder can present with cerebral venous thrombosis. And in the odd occasion, you might see a patient who's completely well and has no past medical history of risk factors, but might have been on the combined oral contraceptive pill, who might present this way. So it's just something to keep in the back of your mind if you're seeing a headache disorder with a number of red flags and neurological signs. So the final headache disorder I wanted to finish off on is idiopathic intracranial hypertension. This is a headache disorder that doesn't present very commonly, but it is an important one to have in mind when you're assessing a patient. The character of the headache is usually non-specific, but importantly, it is brought on by the Valsalva maneuver, and it's important that the headache is not made worse by it, because a lot of headache disorders like migraine are made worse by Valsalva. The important thing to ask is the headache brought on by it? Usually the patients present from the eye casualty or the opticians because the optician has noticed some papilledema, or the patient's reported that they've had some visual disturbance. And also if you do fundoscopy or assess the eye movements, you might find that there's a 4th or 6th nerve palsy. So this is why the examination is a really important aspect in these headache histories. IIH in particular is a diagnosis of exclusion in a particular group, and this usually tends to be young people, often with a high BMI, but not always. And usually you find that the headaches that can be pressure type headaches are related with the papilledema. The usual diagnosis is found by doing a lumbar puncture and measuring the CSF opening pressure, which has to be more than 25 centimeters to clinch the diagnosis. And it's important to do the lumbar puncture in the lateral position to get an accurate opening pressure measurement. Usually the CSF analysis is invariably normal in terms of the protein and the cells, And these are the patients you want to make the urgent neurology referral for, because they can be left untreated and result in permanent visual loss or damage to the optic nerve because of the pressure. So these patients really need to be treated acutely. Finally, just finishing off on some tips for when you approach the acute headache. And this can be anywhere in primary care, can be on the wards, or can be in accident and emergency as well. I usually try to make a positive headache diagnosis, especially if the patient doesn't have a history of headache or a known headache disorder already and they're presenting with new headaches, because that's the best way you will get patient engagement and patient confidence in the condition. Usually saying things like subarachnoid ruled out, headache is not really that helpful for the patient. The main thing to focus on is have that list of red flags, and once you've ruled those red flags out, usually with a good examination, then you can figure out what kind of headache it is and what might you give them for treatment. I usually go on previous headache history, especially in young people in their 20s and 30s. They might play it down, but they might have had headaches in their teens or in their early 20s. But some people may never have had headaches all their lives, and you might make a new diagnosis of migraine in those patients. Examination, as we talked about, their GCS, the focal neurological signs, fundoscopy is key. I appreciate it can be difficult, and sometimes what we do is get the ophthalmologists or the eye casualty in most hospitals to do the examination for us if there is any suspicion. So that can be relatively easily achieved if you're really worried about that. Observations: how high is the blood pressure? Headaches in response to uncontrolled hypertension are not that common, but can be seen. Also, systemically, is the patient unwell? Are they spiking a temperature? Are they tachycardic? So those are things that might point you towards other causes and infective cause. Have a look at the medications as well. So patients with chronic pain who are on a lot of opioid medication or a lot of pain medication overuse headache usually comes on quite insidiously over time, and patients are not aware of it. But these headaches tend to occur when patients are taking numerous painkillers, paradoxically sometimes for headache. And usually the way to stop medication overuse is to cut down dramatically on those painkillers, but that can be a very difficult thing to do. Have a look at previous intracranial imaging, so patients who might have presented with headache before, and it can be quite telling that they might have had a CT head or an MRI head a few years ago with a similar headache presentation, and that really does reassure you that there is no significant risk of a new secondary cause happening here. I usually go with simple analgesia once I think that it's a primary headache disorder. So paracetamol, non-steroidal anti-inflammatories are your first port of call. I usually give them an antiemetic even if there is a slight concern about any nausea, even if the patient doesn't think it's a primary concern, because it does really help. And I give them a course of 3 to 5 days supply to go home with, because you don't want them representing the next day. And as we know, headaches can last for several days at a time. With secondary headaches, they are unlikely to resolve with simple analgesia. So if you have patients who come to hospital or are in hospital and they've had the simple analgesia and the headache's not getting better, then do think about intracranial imaging if you've not already, or a secondary cause, although that by itself is not a very sensitive measure of whether the headache is a primary or a secondary headache. So that's all I wanted to talk about today. I hope you found that useful. I'll just finish off with signposting you to the Migraine Trust, which is a very helpful website both for patients and doctors. It has a lot of information on primary and secondary headache disorders, so you can look at that for further information. Thank you.